Ever thought about how something designed to help a human knee recover from surgery could hold, like a surprising secret to keeping an electric vehicle battery from overheating?
Huh. This sounds like a stretch, doesn't it?
It really does. But today, we're embarking on a deep dive that connects these, well, seemingly disparate worlds.
It really all boils down to the fundamental concept of passive motion, and on the other side, passive cooling.
Okay.
And our sources for this deep dive, they range from clinical studies, years of experience from a major orthopedic hospital, all the way to cutting-edge research papers on battery thermal management systems.
Right, so quite a range. Our mission today, then, is to extract the most important nuggets of knowledge, helping you understand how a core principle can span wildly different fields.
And why that connection is actually, incredibly relevant to innovations happening all around us right now.
Okay, so let's dive into this first part. Continuous passive motion, or CPM. What exactly is it? And where did this idea first pop up in medicine?
Okay, so at its core, CPM involves machine-assisted movement. So a joint is moved, but without the patient actively using their muscles.
Ah, okay. Passive.
Exactly. The pioneering work really came from Professor Robert Salter in Canada. This was back in the early 1980s. He did research on articular cartilage,
Right.
specifically in immobilized rabbit joints. And he found that mobilization, whether it was passive or active, it actually enhanced how cartilage repaired itself.
Interesting.
And it reduced sort of scar tissue formation, adherent tissue within the joints.
So from rabbits,
Yeah.
how did that make the jump into, say, a hospital like the Royal National Orthopedic Hospital, the RNOH in Stanmore? That seems like a big step.
Well, H.W. Hamilton over in America was one of the first trying to replicate Salter's results, but, clinically, with actual patients.
Okay.
He used CPM for patients after surgery on the patella, the kneecap, and he reported the results were, quote, often good.
Often good, right.
Yeah, suggesting CPM might encourage cartilage regeneration, chondroneogenesis is the term, and basically get the limb back to its best possible function faster.
Makes sense.
Then, at the RNOH specifically, it was introduced in 1984 by a Mr. A. Catterall, initially for leg lengthening procedures.
Oh, okay. Why there?
Well, it helped maintain the range of movement and kept the soft tissues extensible, which is really important in those cases.
Okay.
And its success there just led physiotherapists and surgeons to think, hey, maybe this works for other knee conditions too, like elective surgeries, trauma.
So it sounds incredibly beneficial, especially after surgery.
Yeah.
But what did the RNOH's experience tell us about, like, the day-to-day use? Any practical challenge?
Oh, definitely. Patients at RNOH, they routinely remained on these CTM machines for 24 hours a day.
Wow.
Yeah, stopping only for physio, using the toilet, nursing procedures, typically for maybe 7 to 10 days straight.
That's intense.
It is, and for certain procedures, like manipulations under anesthetic of the knee, they'd put the machine on right in the recovery room. Immediately.
To maintain the range they just achieved in theater. Sometimes they even needed thigh and calf straps to stop patients resisting, maybe unconsciously.
Right, you'd need good pain control for that, I imagine.
Absolutely.
Yeah.
Continuous analgesic cover was essential. And for total knee replacements, the favorite approach at RNOH was keeping the knee in a back slab for maybe up to 5 days before starting CPM.
Okay.
Then they'd use the CPM for 5 to 7 days, gradually increasing the bend, the flexion, by maybe 5 to 10 degrees each day.
So a gradual increase.
Right? But, and this is crucial, it was always understood that CPM was only an adjunct, like a helper.
Not the whole therapy.
Exactly.
Right.
You absolutely needed an intensive program of active exercises, especially for the quadriceps muscle, and active knee bending exercises too.
Because the machine does the work, the muscles don't have to.
Precisely. A common issue was something called quadriceps lag, where the muscle wasn't firing properly. So you couldn't just force the knee bend on the machine if it compromised the quad function. It's a balance. That makes a lot of sense. Okay, what about the machines themselves? Any common issues or limitations with how they were designed or used back then?
Yeah, there were definitely practical things. Applying the machine incorrectly, for instance, that could increase the risk of nerve problems, like palsy.
Yes.
And the covers, they'd stretch out, they'd need adjusting, regular washing between patients, hygiene's key.
Of course.
Lead entanglement was another concern. They recommended using plastic ties to keep the cables tidy and safe.
Little things, but important.
And accuracy, too. The machine's own dials showing the range of motion, the ROM, often inaccurate. maybe by a degree or more.
Really?
Yeah, so you always had to measure the ROM directly from the patient's limb, not just trust the machine's display. And if it wasn't strapped on firmly, the whole machine could kind of travel or shift on the bed.
Like wander off.
A bit, yeah. Which obviously reduces how effective it is. So yeah, definitely some teething problems.
Given those early challenges, what have we seen in terms of, like, modern CPM advancements?
Yeah.
Have they fixed these issues? Are they more user-friendly now?
Oh, absolutely. Huge advancements. For instance, there are now CPM machines designed specifically for the elbow and forearm.
Not just knees.
Right. Offering 2 degrees of freedom, so elbow bending and straightening, and also forearm rotation, pronation, supination.
Okay.
And they can do it with like 5-degree increment control. These newer designs are often simpler. Lower cost, one example cited was around RM480, though that's Malaysian ringgit, so cost varies.
Still seems more accessible.
Definitely. Less complex mechanisms, often equipped with GUIs, graphical user interfaces, makes it easier to set parameters, monitor progress.
Like a touchscreen.
Exactly. There's another example, an arm rehab device using something called the cascade control principle, designed for stiff shoulders and elbow.
Cascade control.
Yeah, it's a more sophisticated control system. This device is highly flexible, works for left or right arms without taking it apart, built to be stable, even considering like typical Asian body shapes for better fit.
That's thoughtful design.
It is. Touchscreen for angles and time, smart controller algorithm, emergency stop switch for safety.
Yeah.
It even has soft start and soft stop functions to prevent, jerky movements from the motor.
Smooth operation.
But perhaps the most impressive thing is the development of pain-sensitive CPM machines.
Pain sensitive. How does that work?
Okay, so picture this. A DC motor drives the movement. If the patient experiences pain, they'll naturally resist, putting an extra load on that motor.
Right.
This causes the motor's voltage to drop. If it drops below a certain threshold, say 3 volts, for more than about 1.5 seconds, the machine interprets that as pain.
And then
It stops and reverses direction automatically.
Wow, that's a game changer for patient safety and comfort.
Huge improvement, yeah. Much more responsive to the patient's actual experience.
That sounds like incredible progress. Really making them more patient-friendly, more adaptable. But this raises a question. Does CPM, sort of more broadly, offer benefits for general fitness, or is it really just for rehab?
That's a really important distinction to make. There was a study back in 2005, a 16-week study, looking at this exact question.
Okay.
They used machine-assisted exercise, specifically toning tables on women aged 40 to 65. You know toning tables.
Vaguely, yeah. Machines that move parts of your body for you.
Pretty much. These women averaged 3 sessions a week, 6 different toning tables, each targeting different muscle groups, moving the body or limbs while the subjects were meant to try and resist the movement.
Okay, so some active resistance intended there. What did they find?
Well, they assessed body composition, muscle strength, flexibility, and the conclusion was, pretty striking.
Yeah.
CPM training in this context, quote, did not appear to provide a sufficient stimulus to significantly alter measures of strength, flexibility, or body composition.
Really, no significant changes.
Any differences they noted were minimal, of little or no practical significance, as the study put it.
Despite the anecdotal claims you sometimes hear about toning tables.
Exactly. Anecdotal evidence is common, but carefully designed studies like this are scarce. It is worth noting, though, one report did find significant weight loss if the CPM was combined with a nutritional weight control program.
So the diet component was key there.
Seems likely. So what's the big takeaway here? While CPM is super effective, really important for post-surgical rehab,
Right.
for general fitness or toning, especially if there isn't significant active resistance involved, it probably doesn't provide enough stimulus for major physiological changes in healthy people.
Got it. So highly specialized for rehab, less so for general fitness. That makes sense. Okay, this whole concept of passive motion, using machines to help biological processes, it's fascinating in medicine. But now you're saying this same idea applies to electric cars, specifically keeping batteries cool.